Perfect. Thanks, Tim. So I think it's important for us to realize that most existing solutions were designed to fit the old reimbursement and regulatory environment. So I think this is really important, so I'm going to say that again. Most existing solutions that we're leveraging for telehealth were designed specifically to fit the old reimbursement and regulatory environment. Over the last 3 months, I think this is why a lot of clinicians and administrators often feel like the solutions that they're using are like trying to fit a square peg in a round hole. And so when we start to kind of break down the feature set of the solutions, there's a common kind of suite that we see there. Obviously, the synchronous and asynchronous communication. On the synchronous, it's the live audio, the live video. A lot of that has really turned into almost a commodity nowadays. And so it's a lot of the other features that often start to differentiate, whether it's messaging, how we're moving data, where the integrations are, both for data flowing in as well as data flowing out. Are we leveraging technology that allows us to capture a lot of data quickly, like with images? Of course, outpatient, remote patient monitoring, things like that, multimedia, those are all key components. The documentation has been interesting to watch over the years, as the documentation and billing used to be kind of quarantined in these telehealth solutions, but often more and more that's being done through the EHR. And so when you start to look at the things that are differentiators, I think the network of care team members is one of the key things. Are you needing to access to other clinicians, other specialists that aren't in your system? Or do you have these clinicians that you're trying to make available to provide those services? How you're able to patch together and bring together groups of people that are providing services instead of just point to point with 2 people, often being on either end, especially if you're thinking more telemedicine mindset and clinician to clinician. How many people can we bring together? Where are they? That's starting to turn more and more into differentiators. Tim's going to talk more in a little bit about workflow. I think one of the key things that a lot of us have learned over the last few months is applying non-healthcare specific solutions to the healthcare space in the frustrations and lost opportunity costs, inefficiencies, without specific alarming routing calls, understanding clinical workflows. I think those are all things that are really interesting observations over the past few months, and I think clinicians are getting more and more experience as we're trying to expand the scope rapidly to fit this new environment and to prepare not just for the new telehealth environment, but for additional waves potentially of COVID-19. So on the security side, I think there's always this balance between usability and security. How much are you leveraging patient devices versus basically only web browser versions? Same thing with provider devices. And so I think that's one of the things that we've got to really come to terms with. How much do we leverage because it's easy SMS, whether we think it's secure or not? The more that patients get targeted with SMS, and that's opening a browser, does that open them up to getting used to responding to texts and doing things in more smishing attacks? It's things like that we have to be looking at and evaluating as we're moving forward. And again, I think it's that balance between usability and security, especially in the acute care environment where a lot of our providers are mobile. Another key thing is on the hardware. I think this is a major differentiator. Depending on what you're trying to use the telehealth solution for, sometimes desktop versions are better, but mobile is often better. And some of the use cases that we can look at, mobile technology is much easier to keep clean. It's much more cost effective. If the software or the technologies are built correctly, you can actually leverage both patient as well as provider devices and shared device opportunities. So there's a lot of things to look at and consider. I think what I'd like to do now is kind of look at some of the traditional telehealth solutions out there. With the exception of fax, phone, and radio, this is not beating up on the existing systems or critiquing them. It's just highlighting what they were designed for and used for. So from a patient perspective, the patients are often stable. Obviously, the location was predetermined in many ways. The patients are often stable. What they're seeking care for is pretty well defined. I need an outpatient visit, or there is a stroke encounter going on. From a provider perspective, also, because a lot of these were driven by desktop versions or browser versions in the past, providers were often working shifts specifically to cover telemedicine, or they had allotted time during a day to do it. Often they're stationary, they're in well-controlled environments, they're providing care for something very specific or scheduled. Unscheduled patients and encounters are one of the key things in the acute care space that our systems are basically designed for, but a lot of times our technology solutions are not. Specifically digging into the technology, a lot of the technology we're using is not interoperable with each other, especially when you're looking at inter-organization communication. A lot of that at its core is still fax, phone, and radio. How much time does your transfer center spend leveraging just audio phone calls alone in connecting people? Some of the other things are the interactions. I think a lot of the interactions have been designed in the past to be very rigid, very specific for workflows on a very specific type of event. A lot of times they're really designed to bridge just two silos or two specific individuals at a single time for a very specific interaction or limited interaction. When you look at it from a patient journey perspective, and you look at all the different organizations, especially if you're evaluating the acute care space or patients that are unscheduled, that are considering entering the acute care space, or they're not following your normal protocols and apps that you've provided them, or access nodes or access points, if you start looking at the patients that slip off of that line and start going into more of the acute care space, look how many different organizations that are involved. And when you really start to break down how do we communicate between these organizations, telehealth offers an enormous opportunity. How can you have and leverage live video for these interactions? How can you create a sense of shared consciousness for a specific patient across these organizations? Can you involve the patient on the fly? Again, an unscheduled patient, how do you get them involved where you can do live video? Take a perspective of a burn center who would be this very far end over here. How could they basically accept patients from any other facility or organization using live audio, live video, whether all 350 organizations that send them burn patients, maybe they're not on a specific solution. How do you do that on the fly or get them to join? Other questions are, again, that star diagram on the far right side. A lot of our organizations have fantastic CC&C solutions, but how do those solutions help you with telehealth, with live audio, with live video, with creating a sense of shared consciousness for patients that aren't right now inside of your healthcare system? So I think that starts to highlight some of the opportunities that we have. I mean, the benefits that we can better leverage telehealth for can be not only operational gains, but in the new regulatory and reimbursement environment can also potentially increase the number of billable encounters that we have. So if you start to kind of break down some of the opportunities, we have to realize a lot of our patients are unstable or they're in transition. They're moving between organizations. When they start that movement, a lot of patients are undifferentiated. So if I have one solution for stroke and another solution for ICU and another solution for start to fill in the blanks, these undifferentiated cases, they could be going in and out, in and out, in and out of non-interoperable communication and telehealth solutions. Other things to consider when you start looking at the providers. So a lot of our providers, if I have a tertiary care facility, I'm trying to leverage my providers and make sure other organizations have access to those so that we can provide access in some of these underserved areas. But a lot of these clinicians, they're mobile, they're in chaotic environments. We have to figure out how to grab their attention and bring them onto a case. A lot of the conditions, again, are unknown. I think one of the really important things is if you look at that patient journey slide, there are a lot of middlemen that are involved. The transfer center is a good example. So how do you route something through a rural facility that goes to a state-based trauma network, who then gets moved over to a transfer center and then involves the appropriate trauma surgeon? So these middlemen interactions, if you're focused on just point to point and it can't cross multiple different organizations, how do we bring all the providers on? From a technology perspective, I think there's tremendous opportunity to better leverage mobile and web. I think the goal should be, how do we leverage current cloud-based technology to eliminate silos while protecting data privacy and security? I think being mindful of healthcare-specific workflows is a tremendous opportunity that we have. And from an interaction perspective, I think it's really important that we're looking at thinking about flexible interactions across organizations. So when you start to kind of break down some of the new opportunities that are out there, and these are things that we've been seeing over the last 3 to 4 months, I'll be honest, some of these things we were designed for, but a lot of these things were emergence behavior of basically people looking at the need and trying to match tools to help fulfill this need. So some of the examples are, how do you take 911 calls or hotline calls that are audio calls, convert those over to video, be able to capture the data for this unscheduled patient, and either A, from an EMS perspective, maybe not even send a truck, or B, actually convert it over to a billable encounter. Other things like unscheduled behavioral health, I think that's really important. As an emergency physician, I've lived through years of having chronic patients come into the mental health patients come into the emergency department, and they hit those doors, and it's very difficult to get an appropriate disposition for them. And so now, if you can involve outpatient facilities, mental health experts, public safety, how can we provide better care where they actually are? From an EMS perspective, how can we better leverage video to actually provide medical direction, and in some cases even turn those into billable encounters? How can we work with EMS, whether it's mobile integrated healthcare, community paramedicine, to help leverage our specialists, those mobile resources to prevent readmission or provide chronic care in the patient's home? There are obvious things with transfer centers. How do we create a shared sense of consciousness across multiple organizations with a transfer center as a middleman that's operating logistics and all kinds of other things that they do, but being able to allow them from a consultation manner or from a transfer center mindset, how do we provide that access to all parties involved, both our own specialists within our system as well as in any potential referral facility? We've seen some of the most fascinating stuff in the ED and inpatient spaces. So we've seen areas where they start to undergo a surge in the emergency department, and now instead of opening up other areas in trying to bring in physicians and backlog and stuff like that, they're able to open up lower acuity patients to serve them where they are, and even recruit physicians that are at home that are quote unquote on call to provide those services. One of the things, if you think about limiting PPE and, preserving PPE and limiting clinician exposure. So imagine every emergency patient that comes in that qualifies, that has a mobile device, you can basically in seconds give them an app that they can receive secure calls on, instead of clinicians having to walk in that room repeatedly, donning on their PPE and exposing themselves, even for non-COVID specific patients. They can leverage that video for follow-up visits, follow-up communication, asking additional questions, giving discharge instructions. Other key things are family members. So we've seen a lot of people, obviously we have restrictions in the acute care space. How can we leverage live video and telehealth to basically involve family members in the patient's care when we have visitation restrictions? How can we better leverage telehealth if we're discharging someone from the emergency department, say it's an abscess or a cellulitis, or I need to make sure that there's MDI education. That's a specific code that we can do now. And I can follow up that patient the next day or over the next couple of days instead of having that patient return to the emergency department. 80% of medical errors are secondary to miscommunication during transitions of care. So how can I leverage telehealth in chaotic environments to streamline and simplify transitions of care, even if it's internal? For time-sensitive emergencies, we're doing that across organizations, but what about even within my own facility? A lot of the inpatient scenarios are very similar to the ED scenarios, so I'll kind of speed past most of those, but imagine being able to leverage live video solutions where at-risk physicians or clinicians that are quarantined can still work and provide services if they're feeling up to it, and not physically being at the hospital. We're seeing a lot of virtual care centers that are being spun up. We can start to analyze outpatient spaces in different ways that hospitals and healthcare systems can leverage virtual care centers to better provide care. And I think one of the most interesting that we're seeing out there are the regional systems. So we see a lot of requests from emergency management now, whether they're building a MOC, a medical operations communication cell, so that they can communicate at patient-level details for an incident. So they're used to incidents and have incidents response software, but patient-level details across organizations that can include middlemen, like your EOC. So again, picture a evacuation where there's a COVID surge during a hurricane. How do we manage those patient-level details, do appropriate load balancing, have not a command and control necessarily, but a communication and collaboration middleman that is helping? And those can be used for alternate care sites, long-term care facilities, et cetera. So those are a few of the opportunities that we can look at and assess our telehealth solutions. So I'll pass it back over to Tim for some additional details.